now. Thank you. The next person is Adele. So
Hello.
Dr. Adele Greaves, you're going to speak to us about virtual parent-infant psychotherapy.
Yes, I can see my slides.
Yes.
So it's lovely to meet you all. My name's Adele Greaves. I'm a clinical psychologist in private practice. And when I did this research, I was in an NHS community perinatal mental health service. I'm now in a specialist trauma and dissociation service. You can find me on email and on Twitter, and I'm also a member of Extinction Rebellion Psychologists. So if anybody wants to know more about that, do ask me. So, just to give you the context to perimental health in the UK. So we had a massive expansion of perimental health services in the 2017, and this because there was an increasing recognition that perimental health is a significant public health issue that causes considerable suffering for mothers, their partners, their families, and their babies. To give some stats to that, there is evidence suggests that maternal mental health and suicide is the leading cause of death in the first year postpartum, accounting for about a quarter of deaths. We also know that poor maternal mental health has significant impacts on infant development and outcomes, and that it costs the UK government about 8.1 billion per year, and that 72% of those costs are unfortunately to do with later services for the children as they grow up and their development is impacted by this early adversity. Difficulties in the parent-infant relationship are complex. There's multiple and intersectional causative factors. So this could be their fertility journey, their experience in pregnancy, birth trauma, the developmental and trauma histories of both parents, perinatal mental illness in mum and dad, the wider social context, and the infant's health and temperament. So there was a report in 2021 called the Best Start for Life report by the UK government that suggests that parent-infant psychotherapy can improve outcomes for mothers and babies in this period. What is PIP? PIP is a dyadic intervention, although listening to the talks this morning, I was thinking when it goes online, it becomes a triadic intervention with the technology as a medium, but I hadn't thought about that at the time. So it's usually with a parent and their baby to improve their relationship with the aims of improving parent and infant mental well-being, infant attachment, and healthy development. And generally, there's 3 modes of intervention in PIP. So you can work through the mother's mind, working through her developmental experiences, her experience of being parented, her perceptions of her infant. You can work through the here and now present relationship between mother and baby in the room. And you can also give the baby a voice or speak for the baby in therapy. PIP has different therapeutic aims, so it can support the transition to parenthood, it can enable parental reflective function, it can enable parents to see their baby as a dependent person with a developing mind, it can enable parents to regulate their own and their baby's emotions, and it can interrupt the intergenerational transmission of trauma and also promote secure attachment and thereby promote infant development. So now we come to 2020 and the COVID-19 pandemic, which I was thinking about. It made a difficult situation for mothers even worse. And we know that those negative impacts were more acutely felt by women who were experiencing socioeconomic deprivation and also women from diverse backgrounds. And these additional challenges in COVID related to the impacts of the pandemic on the perinatal workforce. So initially, a lot of us went online because it wasn't felt safe to meet face-to-face. And for example, very early on in the pandemic, when women were giving birth, partners were no longer allowed to accompany them, again, trying to reduce transmission. There were decreases in informal support. So maybe as a new mother, you wouldn't have access to your mother or father because, again, fear of transmission. And all of this created a lot of concern about what the impacts were of mothers and particularly on infant development. And indeed, there was a survey of parents conducted in 2020, and 6 in 10 parents were found to be concerned about their mental health. 9 in 10 experienced increased anxiety. A quarter of parents were concerned about their relationship with their baby, and a third wanted support to improve this relationship. So we had to go online. And like a lot of people have said this morning, there wasn't any preparation for this, but it had to be done. Mothers were vulnerable anyway, but had increased vulnerability during the pandemic. So we moved parent-infant psychotherapy online with very little clinical guidance or evidence or clarity about what the support structures would be to support this new intervention. So due to this being a novel way of delivering vPIP, I decided to do a small-scale service evaluation to investigate the effectiveness and also the maternal experience of virtual parent-infant psychotherapy for mothers with mental health difficulties and their infants. Now, traditionally, PIP is delivered in an environment that is comfortable for mum and baby. And like a lot of people again have said this morning, we suddenly had no control over the environments in which we were seeing mothers and babies, which was interesting. I've met mums in various places in ways you would never have expected. So there was a whole new level of tolerance of uncertainty in the therapeutic encounter, I think, for therapist and client. Another key challenge was how to engage the baby virtually. So often the therapist does form a relationship with the baby in the room. Now, in our informal experience, I think babies can be engaged online via facial expressions, tone of voice, but it's a whole different experience, as a lot of people have been alluding to this morning, and the impacts of that are unclear, especially as somebody who is a digital immigrant versus these babies who would be considered digital natives. We did have a question though, whether working virtually might help transfer some of the knowledge or learning in therapy. But again, this was all hypotheses at this stage. Subsequently, there's also been a parent-infant therapist called Stella Acquaroni who's published a paper suggesting that working in the virtual space may offer advantages and people may be less avoidant online. And there is also evidence about a disinhibition effect online, that people are more likely to disclose and engage. But again, this is all theorizing and hypotheses at this stage. We really didn't know how it was going to be. So, as I said, we aim to explore the outcomes for mothers and their babies engaging in vPIP. We hypothesized that it would lead to improvements in maternal mental health and postpartum bonding. And we also undertook a qualitative analysis using interpretative phenomenological analysis to explore the experience and meaning for mothers. So we had quantitative outcome measures administered before and afterwards, and we had 2 measures: the clinical outcomes in routine evaluation, which is a standard measure of psychological distress used across NHS services, and the postpartum bonding questionnaire, which is used quite widespread throughout perinatal services, although neither measure is without their problems, but they are well validated and used as standard. We also invited all the mothers who participated in the first arm to participate in a virtual semi-structured interview as well about their experiences, but it's important to note that those mothers who did choose to participate were self-selecting. So 8 women took part in the quantitative evaluation and 4 later took part in interviews. The average age was 33. The majority were from white British backgrounds. The majority were married. There was a mix between whether they were first-time mothers or had multiple children, and half the group had 1 mental health diagnosis, half the group had 2. The most common diagnoses were postnatal anxiety and postnatal depression, but there was also birth trauma and complex post-traumatic stress disorder as well. And 7 of the participants were also taking antidepressant medication, just to give you the context. So our quantitative results were very positive. So on the core, we saw statistically significant improvement in levels of maternal distress from pre to post. And on the postpartum bonding questionnaire, it was also very positive, with mothers with increased bonding between mother and baby from pre to post. So this really showed for us that the outcomes of parent-infant psychotherapy can be maintained when you're online, but I will come to a caveat about that later when we come to the discussion.
Right.
These are our qualitative results. So this is the table of themes and sub-themes from IPA analysis. I'm not going to go through these because that would take for a long time, but I am going to go through and just give you some quotes from the participants. So if we think about the vulnerable mother and baby as being our first theme, this theme really encapsulates the participants' experience of perinatal distress that led to them seeking help. All of the participants spoke about experiencing high levels of distress, emotional dysregulation, and trauma. And all 4 participants described unhelpful representations of themselves as mothers and struggling to connect with and understand their babies. I'm not going to read those out. I'm going to move on unless anybody wants me to. I'm going to assume that you're okay to read. The second overarching theme was negotiating the virtual space. So as I was saying, this was a novel experience for therapist and client at the start of the pandemic, and all of the participants spoke about having to manage some frustrations associated with this new virtual space. There were a lot of concerns around technical difficulties, and I know that I was certainly delivering therapy and you would lose connection or you would lose video. And that really was a surface level expression of an underlying anxiety about not being seen and heard by the therapist, particularly when distressed. So there was a real question about, will I be seen, will I be heard, and will I be held? However, having said that, some participants, again, like Geraldine's study, spoke about some new advantages. So there was some removal of barriers to attendance, and that this may have made it more accessible. The third theme was the process of vPIP, and this captured participants' differing experiences of therapeutic processes during vPIP. So a key concern for all participants was whether it was a safe space. And one thing highlighted was the lack of transitional space between therapy and home. And I always remember, because one participant in particular spoke about how when the camera went off, it felt like an abandonment. You were just suddenly shut off without any support. And I think, and you could say it's a reflection of the pandemic as a whole, but this sense of a lack of space and where are the safe spaces was quite profound, I think, for our sample. There were also concerns about whether distress and risk in particular could be safely managed online. All participants expressed mixed feelings about having their babies present, even though they had all signed up for parent-infant psychotherapy. And we wondered whether this was related to kind of juggling, caring for their baby, trying to hold the screen, create a therapeutic space, whilst also concentrating and attending to their babies. So it was quite a lot of multiple tasks to juggle for mothers, which I think was quite difficult. The mums said that their babies were interested in the screen and interested in the therapist. And certainly that was my experience as a therapist during COVID. But it was also, again, it added to their frustration and sense of juggling because the baby wanted to grab the screen or grab the therapist and interact. And again, it kind of added to the tricky dynamics of the situation. All participants spoke about being able to form an effective therapeutic relationship online and the importance of seeing and being seen in facilitating this. They also articulated the importance of feeling cared for and experiencing their own sense of being held during vPIP. Now, I think these findings are really interesting. I'll come on to that. I'm going to jump ahead. 3 of the participants spoke about recognizing that their current distress was connected to their own early experiences of being parented. And this was either as a concern that led them to seek help or as an understanding developed through vPIP. So a core kind of therapeutic theme or process that you would see in face-to-face PIP seems to be maintained online. And then the final theme, everything changed for us, is about the outcomes of vPIP as described by our mothers. All participants spoke about how vPIP increased their confidence as mothers, which also had beneficial impacts on their mental health. And 3 participants spoke about feeling more closely connected with their baby because of vPIP, and partly due to a better understanding of themselves and their baby. The 1 participant who didn't had other interventions online. So as a service, we also ran dialectical behaviour therapy skills groups throughout the pandemic. And that participant was saying, I'm not sure what it was that really helped me. So conclusions. So it seems that women engaging in virtual parent-infant psychotherapy experience the same outcomes of women in a face-to-face parent-infant psychotherapy. And there have been previous large-scale studies that have shown good maternal mental health outcomes. So our study really replicates those findings. In the big study that I mentioned, what has never been proved is whether parent-infant psychotherapy has impacts on babies and infant development. And in this study, we were not able to measure infant outcomes, and it's unclear what the experience was for babies or whether this would have had a beneficial impact. And that is a problem within the field as a whole. And one of my thoughts coming here today is I think it would be really interesting to use some novel infant research methods, such as gaze tracking online and different technical things that technology might allow you to do to really explore some of these questions that are hard to determine with traditional research methods. Now, this sample and this work happened during the COVID-19 pandemic. Women didn't have a choice about the location. It was a unique set of circumstances. We were in a global trauma, which was impacting everybody. We had decreased social interaction generally and specifically with mental health professionals. So one of the questions is, will these outcomes be maintained when it's business as usual and women can make an informed choice whether to go online or not?
Right. Are you nearly out? Yes.
Yep, sorry. So very quickly, virtual therapy may increase accessibility and service utilization, although there's a question whether it also increases social inequality due to digital poverty. All participants felt that it could be a safe space to express their distress and be understood. We can build effective therapeutic relationships online, but there are questions about how do you create a safe space within your home to do this, and additional training and resources for therapists who are doing this. Thank you very much. I meant to finish 5 minutes earlier, sorry. Any questions?
Thank you very much. Thank you. And as you've said, any questions? People got any comments they want to make before we go into the break? One of the things that strikes me, there are lots of things from your talk and from Geraldine's before. But one of the things that strikes me, and maybe it maybe it's not as important as I think it is, but there is something about the transitional space and the lack of, in the sense of, that you can just turn off the computer or whatever, Zoom, and because it's gone. And in the room, you've got all the kind of, things about people saying goodbye and picking up their things and putting on their jackets or whatever. So, there's something about it. It feels as if it's not so abrupt in a way. It's not so that you're gone, disappear. Anyway, but
no, I really agree with you. And I think that transitional space even extends to when you're, if you're traveling from the therapy room to your home, that's more space for reflection, more space for processing that's just lost with this instantaneous medium.
Absolutely. As if we were to go home from this conference, if we met together, we might go home with somebody else, and we have all kinds of interesting things to say and think about it that we're not going to be able to think now.